Right. Extremity trauma involves the components of the musculoskeletal system. So muscles, the bones, the tendons, the ligaments, and the cartilage. These injuries can look quite gruesome. So these injuries can look quite gruesome. But you cannot develop tunnel vision. You have to focus on the patient. Now, objectives. Prioritizing extremity trauma in the assessment and management of life-threatening injuries. That's your goal. We will discuss the major, immediate, and short-term complications and treatment of amputations, crush injuries, dislocations, fractures, impaled objects, neurovascular injuries, open wounds, sprains, and strains. We will discuss the pathophysiology of compartment syndrome, which is extremity injury, which extremity injuries are most likely to develop this complication. We will describe the potential amount of blood loss from pelvic and femur fractures. We will be discussing major mechanisms of injury associated with injuries, potential complications, and management of injuries to the clavicle and shoulder, elbow, forearm and wrist, hand, pelvis, hip, femur, knee, tibia, fibula, including ankle, foot. Now, extremity trauma. Distorted or wounded extremities must not distract from life-threatening injuries. So these injuries can be very distracting. Rarely they are life-threatening, but there is always exceptions. So they are easy to identify, disabling, but rarely immediately life-threatening. But there are exceptions. And if there is an exception, it means that whatever is the injury is putting the patient at risk for shock, or the limb is compromised. There is neurovascular compromise, so the patient is at risk of losing function of the limb. Now, extremity injuries include fractures, dislocations, open wounds, amputations, neurovascular injuries, sprains and strains, impaled objects, compartment syndrome, crush injury. Fractures. A fracture is a break, chip, or crack in the continuity of a bone. The fracture can be displaced or non-displaced, so it can be a closed fracture that is displaced or non-displaced, or it can be an open fracture. If the fracture is opened, it is referred to as a compound fracture. There is communication to the outside world, the danger of contamination exists, and blood loss occurs outside the body. If the fracture is closed, it is referred to as a simple fracture. There is no communication to the outside, no danger of contamination, no blood loss, and the blood loss occurs inside the body. Now, hemorrhage with fracture. A closed pelvic fracture is a life-threatening fracture. So if discovered in the field, it must be addressed before you package a patient for transport. So with a closed pelvic fracture, extensive bleeding into the abdomen or retroperitoneal space can occur. Usually fractures in several places. The patient can lose 500 cc's or 500 mils of blood with each crack. It may lacerate the bladder or large pelvic blood vessels. With a femur fracture can also be a life-threatening fracture. the patient can lose up to a liter of blood. If they have bilateral femur fractures, that would be a life-threatening situation. Dislocations. Dislocation occurs in joints, and the joints within the body fall in 3 categories: limited movement, free movement, no movement. The more movement a joint has, the easier that joint, well, let me not say it that way. The more movement a joint has, the easier it can be injured. Now, when the bones that come together within a joint exceed the range, when the joint exceeds the range of motion, it can result in one of the bones being displaced from its normal anatomic position. This is what is referred to as a dislocation. Now, with dislocation, there is a high risk of neurovascular compromise. And what that means is there is a high risk of the pulse or blood vessel being compromised. There's a high risk for damage to the sensory nerve, and there's a high risk of damage to the motor nerve. So your role as an EMT is to assess PMS. That's the purpose of assessing PMS. You're not doing PMS because the textbook or the skill sheet tells you to do PMS. When you do PMS for a patient in the field with extremity trauma, it is to rule out the possibility of a limb-threatening emergency. If there is neurovascular compromise, the patient has a limb-threatening emergency. They need lights and siren transport to the hospital. Now, management of dislocations. If there is no neurovascular compromise, splint in the position found. If there is neurovascular compromise and there is a long transport time, then you may have to attempt manual alignment under medical direction. So apply only gentle traction in effort to straighten, often best to pad and splint in most comfortable position, and provide rapid and safe transport. With open wounds to the extremities, remove contamination. So if there is gross contamination, remove it. For small contamination, you may irrigate as protocol allows, but irrigation is not to be routinely done when controlling bleeding. It's only for extreme situations. I need to be guided by proper medical direction. Sterile dressing and bandage, pressure dressing if necessary, tourniquet, hemostatic agent. For open wounds with obvious exsanguinating hemorrhage, only time you can change the order of ABCs to CABCs as it relates to trauma. Now, amputations. Disabling and sometimes life-threatening, the potential for massive hemorrhage exists, most often bleeding controlled with direct pressure. The management: cover with damp sterile dressing, elastic wrap, uniform reasonable pressure across the stump, tourniquet if bleeding is absolutely not controlled. Rarely a tourniquet is needed. Retrieve amputated part in a plastic bag, put it on ice or within ice water, transport. All right, now, because the risk of neurovascular compromise is very high, it is important that the PMS assessment is incorporated. So neurovascular injuries, nerves and major vessels run beside each other in the flexor area of major joints. So it is important for us to check the pulse, motor function, and the sensory function. Now let's look at sprains and strains. A sprain, this is injury to ligaments of the joint, and ligaments connect bone to bone. So it's an overstretching or partial tearing of a ligament. It will result in pain and swelling, treat like a fracture. Sprain is also sometimes referred to as a subluxation or a partial dislocation. Strain, this is injury of the muscular tendinous unit. So strain is more specific to muscle and tendon. Tendon connect muscle to bone. So it's an overstretching or partial tearing of a tendon or a muscle pull. Will cause pain and swelling, treat like a fracture. Extremity injuries. Impaled object, do not remove. If airway obstruction is present, that's the only exception. So if there's an impaled object in the face, the only exception for that being removed is going to be if airway is compromised. Apply very bulky padding, transport object in place, no unnecessary movement, motion magnified in tissues. So we don't want any unnecessary movement for impaled objects. For extremity injuries, compartment syndrome. And compartment syndrome is common in the forearm and the leg. So a fracture occurs, the fascia, which is a membrane of the muscle, is compromised, bleeding starts to occur in the fascia, which is not elastic, and pressure builds up in the area of the fracture. And it's usually going to take about 6 to 12 hours for this to start occurring. But when it starts to occur, it can compromise the function of the limb. Now, in the early stages, the patient will have pain and they will have numbness. In the late stages, they're going to have, and the pain is usually pretty bad. They're going to have pain in the late stages. The limb is going to get very pale. The pulse is going to start to disappear. The numbness is going to be present, and they can also have paralysis. And as I said, the pain is going to be pretty bad. So compartment syndrome, forearm and lower leg, most common areas. Swelling compresses the nerves and vessels. In the early stages, you're looking for pain and paresthesia. In the late stages, you're looking for pain, pallor, pulselessness, paresthesia, paralysis, and the pain is progressive and out of proportion to the exam. Now, crush injury. Crush injury is when an extremity is pinned for more than 4 hours. So the area is pinned down or crushed. There is no adequate blood flow. The muscles and the cells start to break down and release toxins inside of the body. If these toxins are allowed to circulate, they can cause significant issues with the kidneys and significant problems with the heart. So crush injury, pressure on the extremities for extended time, usually 4 hours or beyond that. This will lead to anaerobic metabolism. Once the pressure is released, the blood flow to the crushed tissue is reinstated, but that's not necessarily good because it will cause the toxins to now circulate within the entire body. This is crush or compression syndrome. Now, patient assessment. The mechanism of injury will dictate whether the injury is localized or diffuse. So mechanism, history, falls, landing on the feet can cause direct injury to the foot indirect injury to the lumbar spine. Sitting position in a vehicle can cause direct injury to the knee, indirect to the hip. Falls onto the wrist can cause direct injury to the wrist, indirect elbow. Fall onto the ankle can cause direct injury to the ankle, indirect proximal fibula. And for mechanisms associated with injuries to the shoulder, can cause complications with the shoulder, the neck, and the chest. And if it's the pelvis, can be direct damage to the pelvis, and shock may be present for that particular patient. You will perform your primary and secondary assessment. So in your primary, you know what you're doing. Yes, you're assessing LOC, airway, breathing, circulation. Manage any life threats present based on that assessment. After you have completed your ABCs, what is your patient's GCS? Do you need to do a rapid scan? Do you need to do a focus? If you need to do a rapid scan, you do your decap ITLS, TIC. TIC is tenderness, instability, and crepitation. You can do it for the entire body or you do it for the injured part. It depends on whether or not you need to do a rapid scan or a focus. So we're looking for instability, we're looking for crepitation, joint pain, joint movement, distal PMS. If the ABCs are fine, then you focus on the injury. When you're focusing on the injury, you expose, you let your partner control the limb, you check your PMS bilaterally. Based on your findings, you choose the most appropriate splint based on the situation. Stabilize the limb, then recheck your PMS, and you package your patient for transport. It's a load and go situation after your ABCs, then you need to do a rapid scan on the entire patient. You take your spinal motion restriction precautions. Don't delay moving the patient to splint a leg if the entire patient is at risk. Once you get the patient in the back of your unit, you know the next step. The patient is talking, you want to get some information. So it's history, while your partner doing vital signs, the vital signs that you get at that point compared to your primary assessment findings without treatment. So you will know at that point if your treatment is working or not. Patient not talking to you, do your vital signs, consider the information that you can get from persons on location, and consider your physical findings. En route, continue to reassess your patient, contact the receiving facility, do your documentation, monitor your patient, monitor your interventions. That's it. Now, management, splinting. The purpose of splinting is to prevent the motion of the broken bone ends, to reduce the chance of further injury, and in some cases, decrease pain, not in all cases. In a load and go patient, temporary splinting with a long backboard, an additional splinting during transport is what is recommended. Don't do otherwise. Now, rules of splinting. Kind of went over this already. After you have done your ABCs, you're going to focus on the injured limb, expose, visualize the limb, look for signs of an injury, decap, ITLS, TIC. Once you discover that an injury is present, wherever the injury is located, you want to stabilize above and below that. So you need to, if it's a fracture, joint above, joint below. It's a joint injury, bone above, bone below. Ensure that you check PMS. And it's kind of weird to me that EMTs, when they're doing their research, they don't check PMS. So it means that when you're out there, you're not checking it. And again, the purpose of checking EMS is not because it's in your textbook or on a skill sheet. You're doing the PMS check to determine if your patient has a limb-threatening emergency. If the PMS is compromised, the patient is at risk of losing function of the limb. That's a PMS. Now, if a PMS is that important, why are you people neglecting it in the field? I don't understand that logic. Again, if you have too much gaps in your assessment, the patient suffers. Cover open wounds with sterile dressing. Immobilize one joint above and below. Apply one side away from open wound. Pad splint well. Do not attempt to push bone ends under the skin. So once you have visualized the limb, look for signs of an injury. Ask your partner to manually stabilize. Check PMS bilaterally. Choose the appropriate splint. Stabilize above and below the injury. Reevaluate your PMS. Then you move with your patient. Now, extremity trauma, if in doubt, splint, possible injury. Types of splint. Now, you have your traction splints. You have different types of traction splints. You have a Sager and a heel traction splint. The preferred is the Sager traction splint, and the indication for a traction splint is a mid-shaft isolated femur fracture. So it's a femoral shaft fracture with no other complications. For tourniquets, it's very common in the military and tactical setting. It started to become very common in the EMS world. It improves survival, regaining use in civilian population. There are minimal complications. Label patients who have tourniquets. So it's becoming a part of bleeding management. Should not be performed if you have not had proper training and if you don't have it in your protocol and proper medical direction. So you need to be trained properly in the application of a tourniquet, and you need to be trained properly to improvise a tourniquet use if necessary. Hemostatic agents for uncontrolled bleeding, they promote clot formation, and it is used in conjunction with direct pressure. They have not decided on what's the best agent as yet, but research is being conducted now to determine that, because some of the hemostatic agents is causing the wound to get too hot. But again, it's being used a lot in the Army. It's being researched whether or not it's going to be a part of EMS. Now let's look at specific management based on the area of injury. For the spine, it's spinal motion restriction. So most EMS response now will not be using the spine board. They use the scoop or scoop back board. You will assume, you will take the necessary spinal precaution. So you're gonna still do that, but we're using the scoop to move the patient. Once the patient gets to the unit, the scoop is removed. So patients are no longer being kept on spine boards because of the complications associated with these devices. Now, in order to effectively place a patient on a scoop or spine board, 4 persons are needed for that task. Person at the head give the command. Somebody needs to control the upper portion of the body, and the lower portion of the body needs to be controlled. Patient is moved as a unit without the head and neck being shifted significantly. And if the patient is not properly centered on the board, patient is not pushed across the board, which I've seen, some EMTs do on videos of accidents and in the research videos as well. Do not push the patient across the board. For the pelvis, you can improvise using a sheet or you can use a pelvic splint. If a unstable pelvis is discovered, it should not be released until it is properly secured. And it's something that must be addressed within the field. For the femur, as long as it's a femoral shaft fracture and there are no other complications and your protocol allows, go ahead with your traction splint. It's not a device that is commonly used anymore because of how specific its use is. But if it's within your protocol and by chance it's an isolated femur fracture, go ahead. The preferred traction splint is a Sager traction splint. The here traction elevates the fracture. 2 persons are required. An elevated fracture can put your patient at risk for a pulmonary embolism. Now with the hip, which is the neck of the femur, or the proximal end of the femur, your patient can be unstable or your patient can be stable. So the bottom picture is a stable patient. You have time, you make that patient look pretty. And you put them on your device and get them to your unit. You don't have time, you put some padding between the legs, use the uninjured leg to stabilize the injured leg, get the patient to your unit quickly, and you move. That's the difference between load and go and stay and play. So if I give you a patient with a hip fracture and his ABCs are compromised and you're wasting time putting on splints before you put your patient on a device to get them to your unit, you will fail. If you do up top, that's critical thinking, you will pass. So think about your patient presentation. Don't delay transport, especially for a trauma patient. That is critical. Now with the knee, vacuum splint. If your company rich and have all of that device available to you. Don't have a vacuum splint, then you can use pillows. So splints will fall in 3 categories: rigid, formable, and traction. So a pillow can stabilize a knee. You can use longboard splints to also stabilize a knee. You have options once you understand the principle of stabilization. For tib-fib injuries, splint, board splint, padded board splint, roller bandages, or triangular bandages. If the fracture is below the knee, 1 splint is sufficient. If the fracture is at the knee and above, then you should be considering the use of 3 splints or 3-point stabilization. Now, if it's above, if it's at the knee or above and it's only 1 splint you have, then you use the 1 splint. Now with the clavicle, a simple swing, a simple sling and sway would be sufficient. But with the clavicle, it's going to be a high sling. For the shoulder, sling, sway is sufficient. However, you keep the limb low and you put padding between the injured limb and the patient's body. With the elbow, if you have 1 splint, you can use this method. So you use a rigid splint to catch the forearm in the hammer fist position, put it in a sling, and then you use a wide sway to catch the humerus. So the humerus and the radius ulna is secured. Bone above, bone below. The joint, the elbow is where the injury is at. For the forearm and wrist, you can use an ear splint if your company has one, but an ear splint can only be used for a straight fracture. Company doesn't have one. Padded splint, forearm in the position of function, can secure that with your roller bandage, preferably crepe bandage or triangular bandages. For the hand, again, rigid padded splint, roller bandages or triangular bandages maintain position of function. For the foot, can be a flexible splint, can use a pillow, can use a SAM splint, and you want to stabilize above and below, or limit motion. For your crush injuries, frequent ongoing exams. Now, you wouldn't be able to treat for hyperkalemia, which is because of the potassium that's leaking out. So you're gonna have to request ALS if you're working in that type of system. If you're not working in that type of system, you're gonna have to use a tourniquet on this patient. Once the crush mechanism is removed, get them to the hospital as soon as possible. Notify the hospital as soon as possible that they can prepare to do these procedures. So hyperkalemia is going to occur as the muscles break down. There's a high level of potassium inside of the cell. So when the cell breaks down, that leaks out into the blood and it causes significant complications with the heart. So the patient is going to need fluid resuscitation. They're going to need calcium gluconate or medication to cause the potassium to flow back where it needs to go. They're going to need alkalizing of the blood because they're going to have acidosis. So they will need fluid resuscitation. They're going to need sodium bicarbonate, which is the NaCO3 infusion. We use sodium bicarbonate to treat acidosis. And they're going to need osmotic diuretics to balance the blood pressure, because when electrolytes move, if their concentration start to increase in a certain area, water is going to follow that concentration. So the patient is going to need to balance out their blood pressure. Definitely need to think about a tourniquet application in Jamaica because ALS is not available, and that is what is going to buy time for this patient. If the crush mechanism is there and it is removed and no tourniquet is applied, all of the toxins is going to circulate inside of the patient. Their heart is going to start to have problems and their kidneys is going to fail. Now, in summary, the primary assessment has priority. So again, always do your ABCs, rule out the possibility of life threats. Extremity trauma, not usually life-threatening, but you have the exceptions. Pelvic femur fractures, these injuries can be life-threatening. Address them as such. Proper splinting decrease further injury, dislocation of elbows, hips, and knees. Careful splinting and rapid reduction may be necessary depending on the transport time to prevent severe disability. And that would be the end of this lecture.